Today at the National Press Club, Professor Stephen Robson, the Australian Medical Association President. He'll talk about how to improve the health system to ensure better care, detail ways to make the workforce more productive and generate new sources of revenue. Professor Stephen Robson with today's National Press Club address.
Good afternoon, ladies and gentlemen, and welcome to the National Press Club and the Westpac Address, coming to you from Ngunnawal and Ngambri country, Canberra. My name's Laura Tingle and I'm the club's president. In recent times, there has finally been a recognition in federal politics that our system of general practice is in crisis. It's not just plummeting bulk billing rates, but an economic model which is not sustainable for many doctors. COVID-19 only exacerbated and exposed problems in public hospitals with the ramping of ambulances, an all too common phenomenon around the country. The broader health system, from aged care to the NDIS, is also under immense pressure. Professor Steve Robson is the Australian Medical Association's federal president, and a month after the federal budget, we welcome him here today to give his first address to the National Press Club. Please join me in welcoming him.
Thank you very much, Laura, and thank to all of you for joining me today. I'd like to begin by acknowledging the traditional owners of the land on which we're meeting today, the Ngunnawal and Ngambri people, and pay my respects to their elders past, present and emerging, as well as any Aboriginal or Torres Strait Islander people present in the room today. Thank you. The first big talk I ever gave was about 30 years ago, almost to the day, and I'd done about a year of research that I was presenting at a big surgical meeting as a trainee. When I arrived, in addition to my supervisor and I, there was one person in the room, in the audience. And I have to say, I was very disappointed. And I went to my supervisor and said, look, this is so disappointing, having done all of that work, and there's one person here. And he said, Steve, don't get too excited. You're talking for 12 minutes. There's still plenty of time for him to leave. So I'll be watching the doors today. When people are asked what is the most important thing to them, we hear two responses: their family and their health. If you survey people around the globe, you always get the same answers. Good health is the foundation that allows us to pursue our life's goals. So it's not surprising that when Ipsos surveyed Australians and asked what makes somewhere a good place to live, the two top responses were that somewhere they felt safe and access to good quality health services. The impact that health has on people's lives is the essence of what I'm talking about here today with you. That investing in health is not only good economic policy, but investments in health can make a huge difference to the well-being of Australians. We're now in the fourth year of a global pandemic. COVID-19 is the third most common reason that Australians die. 20,000 more Australians died in 2022 than we'd expect to have died had there not been a pandemic. And the pandemic has also shown us just how important health is to our economy, both here and overseas. COVID has had an extraordinary impact on our communities and our healthcare system, and particularly our healthcare workforce. And the pandemic has also demonstrated something quite remarkable, that with the collective will of governments, the community and healthcare professions, quick and innovative solutions backed by investment are actually possible. 2 years ago, the previous AMA President, Dr. Omar Khurshid, stood here and reminded us that health was the best investment governments could make. He proposed a goal for Australia to become the healthiest country in the world. Well, now's as good a time as any to take stock of where we are in relation to that goal. Where we stand as a healthy country depends on what data you choose to use. And it's really important to understand that health is not just the absence of disease. If we use the Bloomberg Global Health Index as our metric, then we're number 7. We're behind Sweden, but ahead of Canada and the UK. But if we look at Australia's health system from a different perspective, that of unmet need and equality and inequality of access, as the OECD has done, then we actually slip behind the UK and comparable European countries. And while the health system is considered to be one of the best in the world, around half of all Australians now have at least one chronic disease, and our population is rapidly ageing. Are we at risk of an already strained system cracking under further pressure? Well, when Dr. Khurshid released the AMA's Vision for Health here 2 years ago, he committed the AMA to applying an economic lens to the policies that we propose. Well, I have a personal interest in the economics of healthcare. As president of the College of Obstetricians and Gynaecologists a few years ago, the two key issues that I had to face were out-of-pocket costs for maternity care and the harms caused by transvaginal mesh. I had meeting after meeting with bureaucrats and health economists, and I had to respond commonly to commentary by health economists in the medical and the lay press. What became clear to me was that very few economists understood what it was like to spend the night on a birth suite, trying to comfort a woman and a partner while they're in labour, but at the same time trying to keep the mother and baby safe, all the time knowing that you're going to be performing quite difficult surgery all the next day. So I think the economists I met regarded doctors as wasteful, and I, well, not wanting to offend those economists, I thought they had no clue what it actually felt like to provide health care to vulnerable people. I wanted to bridge that gap and become fluent in the language of economics so I could cross the divide between the economic theoretician and the practising clinician. I'm kind of getting there, although slowly. So with my very nascent health economist hat on, I asked the question, is there any robust economic evidence that health investment leads to good economic outcomes? Well, in 2005, the Centre for European Policy Studies reviewed all the available evidence and concluded the answer was a resounding yes. That resounding yes, the Centre said, had a critical implication for policymakers. It provided the justification for investing in health to achieve economic outcomes. The value of investing in health was also clearly demonstrated during the pandemic, where strong public health measures and labour market policies kept Australians engaged in the workforce. This is one of the reasons why Australia's economy has fared so much better than many others. In general terms, when we look at the outcomes of poor investment in health and include that bad policy, we also see a difference. While the UK now is ahead of us on its health spend, chronic underfunding of the British NHS has led to near collapse of their health system and an exodus of healthcare workers to countries like Australia. At the other end of the scale in the US, the poorly designed health system, where health expenditure eats up almost $1 in every 5 spent in the biggest economy in the world, has a system that delivers some of the worst health outcomes in any high-income country. So balance is everything and good policy is everything. But while we rate reasonably well on health investment, scratch the surface of our health system across public health, primary care, public hospitals and private health, and the story is not what we'd hope for nor expect, and it's definitely not what we think we should accept. For example, there's no way to dress up what's happening in public health in this country. As I noted earlier, half of all Australians live with at least one chronic health condition, and 1 in 5 of us have 2 or more. We have the highest prevalence of obesity in the OECD, and 9 out of 10 preventable deaths in this country are associated with chronic disease. Since the closure of the Australian National Preventive Health Agency in 2014, we have not had a comprehensive funded prevention agenda. There is currently no compass. There are pockets of positive activity, but there doesn't seem to be an overarching coordinated plan. The need for a comprehensive public health agenda is languishing in what appears to be a very big too hard basket. And the short-term electoral cycle means that we're unable to contemplate the investment that is required in something that requires decades of commitment. I think it's fair to say most Australians, and certainly those in this room, are aware of what's happening in primary care, the linchpin of the Australian health system that has general practitioners at its very centre. The Medicare system as we know it was established by the Hawke government in 1984 when I was a medical student, almost 40 years ago. At that time, the rebates it offered to Australians reflected the cost of providing services reasonably well. Well, times have changed. the rate at which the Medicare rebates have increased never kept up with inflation. And remember, we had increases in the Consumer Price Index reaching 6% back in the early 2000s. The pathology sector has not seen its rebates increase since 1999, before the turn of the millennium. The costs of running a practice have increased along with inflation, while the annual increase in Medicare rebates typically was around about 2%, and then it was frozen for the better part of a decade. This neglect has left patients and the practices that wish to bulk bill with ever-increasing costs but a dwindling Medicare rebate, still pegged to numbers that were generated in the Hawke era. Over the same period, more Australians have been battling with more and more chronic health conditions. When the AMA analysed a single Medicare item, that for the most common GP consultation, we found that since over the last 3 decades, 1993, Australians have been underfunded about $8.6 billion. That's $8.6 billion in underfunding from simply one item, and there are more than 5,700 items in the medical benefits schedule. The latest Productivity Commission report showed we spent less on GPs per capita in the last financial year than we did the year before. How is that possible? Well, our report into general practice measured the increased demand on general practice due to population growth, ageing, increased need for visits and complexity. We concluded that within a decade, Australia is likely to be short more than 10,000 full-time general practitioners. The Australian General Practice Training Program hasn't been able to fill its training places for years after the Abbott government cut the key programs that actually encouraged young doctors to take up GP training. So Australians are now experiencing the consequences of decades of neglect of general practice by successive governments. So let's turn to our public hospitals. While our primary care system continues to struggle, the issues in our public hospitals have been laid bare by story after story. People unable to get from an ambulance to a bed, unable to get an operation, unable even to get to see a specialist to get onto a waiting list. Public hospitals are the pivot of our health system. Last year alone, there were almost 7 million hospitalisations in Australia in public hospitals and 22 million patient days of care provided. Yet despite this incredible demand, over the last decade, the connection between funding and the performance and improvement outcomes has been removed. And every year since that connection was lost, the AMA's annual public hospital report card has shown longer and longer waiting times in emergency departments and in our operating theatres. Pressures on our public hospitals mean Australians are dying in ramped ambulances or, in terrible cases, waiting for ambulances to arrive. We have a highly trained healthcare workforce who are desperate to provide care, but they don't have the resources they need to do it. As we age and develop more and more chronic disease, the number of beds in our hospitals is actually falling, especially those for older Australians. Statistics released only a fortnight ago show we actually treated fewer patients in hospital than the year before. But Australians waiting for care in hospitals aren't statistics. They're people in pain, people who can't see, people who can't hear, walk, people who can't work, and people who can't provide care for others. The private health system is one of the important pillars of our health system. Most planned operations in this country are performed in Australian private hospitals, and people who have that care are supported by private health insurance. A couple of years ago, we were very fearful that the uptake of health insurance was in a death spiral. But as our public hospitals have continued to struggle with an unprecedented backlog, many Australians have begun to take out private health insurance again as they face years of waiting for care in our public hospitals. I believe the apparent surge in private health insurance uptake is going to prove to be a mirage. I think many people will fulfil their waiting times, have their procedures, and then relinquish their private insurance again. And if you look at the drivers of uptake, many young Australians take up private health insurance for 2 main reasons: mental health, maternity care. But we're seeing private psychiatric and maternity hospitals closing around the country. So for people who took out health insurance for these reasons, it is going to look like fool's gold. And as cost of living pressures bite harder, you can be sure the struggle to get people into private health insurance is going to return. And there are other dark clouds on the horizon: an ageing population, fewer babies born, the health effects of climate change, and new technologies such as artificial intelligence. We don't know where these are going to take us. It's time to change the narrative around investing in health and not only make an economic case, but a wellbeing case for that investment. And today I'm releasing our research report, Health is the Best Investment, shifting from a sick care system to a healthcare system. Health should not be seen just as a spending portfolio. It should be seen as a productivity portfolio, and we should be spending to save. And the evidence abounds for these benefits, and I want to give you some examples. The measles immunisation program, one single measure, is estimated to have saved us $13.7 billion. Plain packaging on tobacco products is likely to have led to productivity gains of almost $400 a year for every person that did not take up smoking, and $100 a year for every person who quit. It's been estimated overall that the investments we've made in health have led to a life expectancy increase of more than 34 years. So those investments have delivered real economic outcomes for the country. We estimate that to date, keeping Australians 55 years and older, healthy and in the workforce, has resulted in a 2.5% increase in GDP. So that represents $57 billion over the last 14 years. At a time of workforce shortages, it makes good sense to have every Australian engaged in the economy to their peak. But past successes will not tackle future problems, and they won't help hundreds of thousands of people who are waiting for care or tackle the increasing burden of chronic disease. And as our report shows, the number of years that people live in ill health is actually increasing. It's almost 10 years now for males and 11 years for females. So as a society, the time has come for us to alter course, to innovate and to create a health system that focuses not just on keeping people living longer, but one that helps us lead healthier and more productive lives. This is not just about increasing expenditure, it's about improving efficiency. It's not about improving access to care, but also the quality of the care that people receive. And if we can do this, then we can return a dividend not just to the quality of Australian lives, but the quality and strength of our society. I want to give you some examples of how a will to act can make a big difference. Let's start with public health and specifically vaping. E-cigarettes have flooded our schools and are hooking the next generation on breathing in a toxic cocktail of chemicals. Many e-cigarettes are clearly marketed to, designed for and targeted at our children. Vaping has led to an increase in smoking in the under 25-year-old age group for the first time in years. I'm incredibly pleased that the Health Minister has listened to the AMA and to the wider sector by putting in place tighter controls on vapes. And we must prevail if we don't want to face a costly public health catastrophe. The AMA also supports the WHO's recommendation and has campaigned on the economic case for a tax on sugary drinks. In our Sickly Sweet campaign, we've worked with our alliance partners to press the case for action. A sugar tax is a win-win-win scenario. Smart policy that raises revenue, saves lives and healthcare dollars. AMA modelling suggests that a tax on sugary drinks would result in 16,000 fewer cases of type 2 diabetes, 4,400 fewer cases of heart disease, and 1,100 fewer cases of stroke in the next generation. It could also generate about $800 million in revenue for the government over the forward estimates. This idea is ripe for a government to adopt, should they have the political will. And as an AMA, we are going to continue to advocate for this. In the public health arena, there are important lessons we can learn from Aboriginal and Torres Strait Islander communities. Health in Aboriginal and Torres Strait Islander communities encompasses the whole person, the physical and the mental, the internal body as much as the external environment, the individual and family, and the community and wider society. Belonging, recognition, having a voice and being heard, all of these things shape health outcomes. And that is why the AMA is supporting a voice to Parliament. We need to continue to listen and learn and continue to support Aboriginal and Torres Strait Islander peoples in efforts to close the gap on their health outcomes. I'd like to further explore the economic and wellbeing arguments for investing in our health system. Let's begin with primary care. When the OECD studied the economics of primary care, they concluded that highly functioning primary care makes health systems more efficient, reduces rates of avoidable hospital admission, and saves people from needing emergency department care. And the OECD has also provided an important warning. The biggest shortcoming in primary care came with any reduction in the general practitioner workforce. And lastly, the OECD also highlighted the value of telemedicine in productivity gains, the value of teams where doctors work with nurses and pharmacists together, not in silos. Last year, economists at the Wellcome Trust published a review of over 10,000 economic papers and reports that addressed health system efficiency. They concluded that having a GP as the first point of contact, where a patient is required to have a referral from a GP to see another specialist, both enhanced health system efficiency and reduced healthcare costs. There's no question that primary care is the most efficient part of any healthcare system, including ours. Look what happened when we unlocked the productivity boost of telehealth. The Productivity Commission estimated that time spent in doctors' waiting rooms, including mine I'm sure, costs the economy almost $1 billion a year in lost productivity. And our report has shown that patients travelled less for the same care and are likely to have saved $1.35 billion in travel costs in the last financial year alone. And many GPs are able to manage more patients through telehealth. Imagine what we can achieve and unlock if we engage in much wider system reform. In 2022, the AMA launched our campaign to modernise Medicare. We argued that Medicare needs to fund more time with your GP team through longer appointments, extended after-hours access, and provide greater levels of support for vulnerable communities. Imagine also a primary care system that cares for the tens of thousands of Australians with chronic wounds. Instead of requiring people to bounce between their GP and pharmacy to purchase wound care supplies, we could design a seamless system that supplied all of it at once, with patients at the centre. We demonstrated how wound care schemes for diabetic patients alone are likely to save the health system almost $9 for every dollar invested, and at the same time free up around 150,000 GP consultation spots. Then something unexpected happened. The government listened. Last month's budget saw substantial investment to support general practices to engage more nurses and allied health professionals, provide longer consultations, support vulnerable and disadvantaged patients, and fund new programs to strengthen the links between aged care and primary care. The wound scheme for diabetic patients, as we modelled, is now funded. We also saw additional indexation of the MBS at last, underpinned by a new methodology. These decisions have provided immediate and very welcome support for general practice. They're also an important first step toward long-term reform, and they send a message that the government understands the critical role of general practice in our health system. The Minister acknowledged lots more is needed, and we agree. And we will hold the government to this. On public hospitals, our Cycles of Crisis report highlighted the inadequacy of the current funding agreement, an agreement that needs a total refresh to deal with the pandemic legacy that's left our hospitals in such a mess. The current agreement does little to improve performance, it ignores quality, and has no focus on preventing avoidable admissions, which is perhaps the biggest problem of them all. The AMA's Hospital Logjam campaign is all about highlighting the resources and investment needed to navigate us through these current crises. The state premiers agree these reforms are long overdue. Meanwhile, our hospital exit block report estimated that we could save more than $2 billion a year if we addressed exit block for those waiting for aged care and NDIS services. Every day a patient who has finished their treatment remains in a hospital bed waiting to be discharged somewhere is a day another patient who needs that bed goes without. Earlier I mentioned statistics released a fortnight ago that show we treated fewer patients than last year before in hospitals. I didn't tell you the second part. The number of patient days over the same period was actually higher by 600,000. So the only way you can treat fewer people and provide less surgery but use more patient days is a combination of exit block and having your beds taken up by sicker patients. We have to act on this. We're delighted the government has made important gains in reducing bed block for NDIS patients. That was extremely encouraging. And there's more positive news in the budget, almost $100 million to link hospitals and GPs together to tackle avoidable hospital readmissions. This was one of our 4 key asks as part of our hospital logjam campaign. It's a good, if modest, start, but Australians waiting for elective surgery remain waiting for action. Our research report addressing the elective surgery backlog modelled the backlog to be more than 500,000 Australians by the end of this financial year. The report I'm launching today puts a figure on the cost to the economy of lost wages from those patients languishing on public hospital surgery or waiting lists. A staggering $4.6 billion in lost productivity every year. But the truly staggering impact of the hospital logjam campaign isn't the money that's lost. It's the people it leaves desperately waiting for care. So I say to all health ministers, the current review of the National Health Reform Agreement is your chance to hear us. The AMA has a plan, we have the costings, and we have the support of many of the states now. Now is the time to act. As I mentioned earlier, the private health sector is a key pillar of our national health system. But reforms to the system are few and piecemeal, and again, there's no overarching vision to make the sector sustainable. That's why we launched our prescription for private healthcare reports. Our analyses revealed that the public policy levers underpinning the private health system are really no longer calibrated to society. It demonstrated to the Department of Health and Aged Care the need to review lifetime health cover, premium rebates, and the Medicare levy surcharge settings. In response to our report, the Department commissioned further work to investigate these suggestions and has recently released the outcome of that work for further consultation. But we need more to drive this policy further. If taxpayers put significant funds toward private health, we must ensure it is in the most efficient and impactful way possible. We also need to protect not only patient choice, but include safety nets to guard them against contractual disputes between insurers and hospitals that we see in the media. That's why a follow-up report on private health took on the bigger question: how do we drive reform in a sector that has multiple government and non-government players seemingly at odds? Well, last year we brought together the entire sector at Parliament House to discuss this very question. We launched a discussion paper on a way forward for the whole system, and we called for the establishment of a private health system authority. It is way past time that we have an independent body established to oversee the $11.4 billion of government investment in private system every year. Instead of conflict, we call for consensus. Already we've seen key players in the private system join us, and we'll continue to work on advocating for the rest, and we believe these reforms are possible. Today I've sought to demonstrate to you how investment in healthcare makes good economic sense. But I'm not the only one saying this. As it turns out, last week's edition of the British Medical Journal was devoted to this very issue. In its editorial, the BMJ said, and I quote, "For too long, societies around the world have tended to see money that is spent on healthcare as simply a cost to be borne. But if you don't see health as an investment, you do not consider the importance of health when formulating economic policy." And the journal's leading article, written by Mariana Mazzucati, the Professor of Economics at University College London, set out the case for, and I quote her again, "a redesign of international financial systems to treat spending on health as a long-term investment and to increase the fiscal space available for that investment." I'd like to give you an example of how Australians are being let down by our current system. A substantial part of my professional career has been devoted to endometriosis. It's a disease that affects 1 in 9 Australian women in the prime of their lives. Endometriosis can have severe effects on a woman's ability to work, her relationships, her family life, her ability to exercise and stay healthy, to start a family, her very self-esteem. Endometriosis can cause mental health problems and can be debilitating. There are often long delays in diagnosis. Tests for endometriosis are expensive, and the longer it remains untreated, the more severe its effects can be. Yet despite all of this, the national guideline on the urgency category for endometriosis surgery in Australian public hospitals is category 3, the lowest and least important category. National data tell us that tens of thousands of Australian women remain on public hospital waiting lists around the country, their lives severely affected by endometriosis and their condition worsening. They spend time in emergency departments seeking care and pain relief while they wait, and they may end up requiring expensive fertility treatments such as IVF. Many will abandon our public hospitals and seek surgery in the private system and look for financial help from parents, family and sometimes friends. If you step away and take the Treasury view, not of compassion, but of fiscal economics alone, there is an overwhelming case to manage a condition like endometriosis early and well. And at a time where our prime age workforce is shrinking, making sure every single Australian is functioning at their peak should be a no-brainer even for Treasury. While endometriosis is a condition with which I am very, very familiar, there are many other similar conditions. So I'd like to return to the idea of what matters to people, their family and their health, the things that most matter to people. I'm hopeful that the Treasury's focus on measuring what matters genuinely means what it says, because that means there is real potential to re-envisage what the health portfolio could be. Not a cost to bear, but an investment to make. An investment that can change lives and improve a nation. In the meantime, the AMA will continue to make sure patient stories reach the ears of our decision makers. Because at the end of every budget line item, every GDP statistic, every health measurement is an Australian. And helping them from ill health to good health is not just the right thing to do for them, it's something that will benefit all of us. Thank you.
Well, thank you so much. That's a very comprehensive survey of the landscape. If I could just start at that level of people. During the worst days of the pandemic, there were lots of stories that my program and others did where we were documenting, just the absolute exhaustion of hospital workforces. We hear a lot of anecdotal stories about people just leaving the system because of that exhaustion and the trauma associated with working through that period. Can you give an audience who doesn't see the hospital system up close a sort of a sense of where it's ended up now? Is it sort of more or less back to functioning, albeit with all of those existing problems it's got? But what's the state of the workforce? Have they been able to recover? Obviously there are shortages, but what's the sense on the wards?
Laura, it's a fantastic question. When I was driving home one night this week, I was listening to ABC Classic, and Slava Grigorian has just released an album, I don't know if people know, and it's been devoted. He's written guitar music about the experiences of healthcare workers. And I was driving home and they played a piece called Winter, and it was about a healthcare worker, or how Slava thought a healthcare worker would feel driving home after a shift at the peak of the pandemic, looking forward to going home to bed after just exhaustion and being overwhelmed. And it was a beautiful guitar piece, and it actually made me emotional because I remember what things were like at the peak of the pandemic. Now, I'm a pretty resilient person, I can only imagine what all of my colleagues, whether they are nurses, whether they're doctors, whoever it is working at public hospitals, the fact that you cannot have been through that and not have both had a sense of exhaustion, that to me makes me emotional down the track listening to a piece of guitar music, because that's what it's about. But it made many, many of my colleagues question, is this really the right thing for me? Because I don't think anyone, when they trained, really knew that they'd be training into a pandemic and what that would mean. And in many cases, the resource sacrifices that they'd need to make. And I think we've seen this reflected in the health workforce. A lot of people have moved out of health. We've seen high levels of burnout and stress in the health workforce. So I think it has ongoing implications moving forward, and that makes it very difficult to build a new workforce. And a lot of the young people, whether they're nurses or doctors, whoever, who trained during the pandemic, training was really hard. They didn't get that experience. So I think, I predict it will have an effect on the health workforce for another decade to come. I think it will be very difficult for Australian healthcare workforce to get over what they've been through.
And to what extent is there a trauma element involved in that? I mean, people were going, before vaccines came along in particular, people were going into work and having to make decisions about whether they'd go home or not, you know, at the risk of exposing their families.
I think many people in healthcare experienced this moral injury from the peak of the pandemic. And I had exactly the same thing. I have young children here, and they probably remember we had discussions at home. If I came home from working, should I actually stay downstairs? And we've got a bit of a granny flat area, and dump my clothes at the door and just stay down there and try and keep away from the family before vaccines. When we were seeing images from, I'm sure the kids were happy not actually having me snooping around at home, so it wasn't all downside for them. But it was a big thing for the family. And I think that's a thing that people at nursing school or medical school or wherever never really envisioned having to deal with. And I think it affects how you see your profession and what you want to do, and do you really want to work part-time and so on. So they're really big issues, and it's great to hear someone acknowledge that from the workforce perspective. Thank you.
Julia Hare has a question.
Julie Hare from the Australian Financial Review. Thank you very much for your speech. It was reported in the AFR today that Genesis Care, Australia's largest cancer treatment company, has filed for bankruptcy in the US. It's also been discovered that the company had a malfunction in its buy now, pay later services for cancer treatments. How often does Medicare fraud, if I could use that word, happen as far as you're aware in corporatised health? And do you anticipate any changes to cancer care and after the uncovering of this billing problems and the bankruptcy of the company?
Yeah. Look, another very good and topical question. And as you know, as I took over as the AMA president, there was a very big public media discussion about how in particular, the government investment in healthcare is managed. My own personal sense has always been to be a good steward of the health system, but I recognise that may not be universal. So Minister Butler called a review, and Dr. Pradeep Philip reviewed the system. I guess the first comment is that many of the claims that were in the media at the time weren't supported by Dr. Philip. He did report that there was a wide confidence interval, but some significant amount of money that it's difficult to say how it was spent in the health system. But he acknowledged a couple of really important things. One is that the overwhelming majority of doctors are very, very good, thoughtful and mindful stewards of the healthcare budget. And in fact, that coincided with research that had been going on for a couple of years from one of the Sydney universities that found that in fact GPs were so terrified of getting an audit, they were probably underbilling to the tune of $500 million a year just so they didn't trigger an audit. So there's a high degree of concern about the systems in place. Medicare is unbelievably complex. It has close to 6,000 individual item numbers with complex rules and descriptors. And my own practice have had the example of, or the experience of ringing the Medicare helpline and getting, what is the right thing to charge here, getting one bit of advice one day, a conflicting bit of advice the next day. So there's enormous complexity. I think there's no doubt when there's complexity, there's the potential. I think Dr. Phillip himself said there's the potential for fraud if this isn't managed well. The AMA's spent many, many years working. I've been involved in this. We meet with the health department. We look at data and try to work out, is this really reflect what we'd expect expenditure to be in the health system? And I was part of the MBS review where we tried to simplify all of this. So what's my answer to your question? It's an incredibly complex system. Any complex system is potentially subject to misuse. I absolutely concede that. I think anybody who willfully misuses public funds like this needs the book thrown at them. I have no sympathy and I think action should be taken. But I think at the end of the day, a lot of these things are symptomatic of the complexity in the system, and trying to resolve that is the way that we're going to ultimately make sure that we all are good stewards of the health system.
Simon Gross.
Simon Gross, Canberra IQ. Your talk and the paper you put out today is about like a strategic approach to optimising the spend, the health spend. Like another angle on that is the One Health paradigm, which is human health is part and parcel of animal health, or keeping animal health, but they're part and parcel. Now, so my question's about biosecurity. Indonesia, about 6 weeks ago, declared FMD as endemic. We've got swine fever in Timor and PNG, I think. Varroa mites coming in. So, both sides of politics have been onto this over the last 2 or 3 years, but it's these things are pulsing across the Arafura Sea and the Torres Strait. So how do you assess our biosecurity effort, and would you do anything different?
Yet another great question. So I think one of the things the pandemic has taught every single person around the globe is that we are not isolated from the rest of life on this planet. And the One Health paradigm, for those people who don't know, is that we need to look not just at human infection, for example, but consider the ecosystem around us with animals and look at potential threats to human health. And we know that it's very likely that COVID, for example, came from animals in a wet market and crossed over. And I think many, many people around the world are anxiously looking at bird flu at the moment, which seems to be teetering on the brink of moving to humans. And if it does, it's going to be a catastrophe. I think it's actually symptomatic of a broader issue that as humans, we are bespoiling the planet. And I think it's absolutely clear that human action is affecting ecosystems to the point where it's a threat to human health and existence if we do not manage it well from this point forward. Biosecurity, I'm no expert in biosecurity. I used to be in the Navy. I was a Navy officer, so I have some experience of issues in the region. I think getting the settings right on this is difficult because there are many groups who would like to, I guess, make sure there are fewer, restrictions on the ability to trade across borders. But getting that advice right is hard. And I think I'd go back to the principle that I think is really important for a lot of things we do. Listen to the experts, keep the politics out of things. And I think if we do our best to follow the expert advice, not put too much of a political angle on things, I think we're likely to be able to steer the most appropriate course. But I stress I'm no expert on biosecurity, but I acknowledge just how important it is for all the reasons you articulated there.
If I could just take a slight careering off the path about that. One of the things that sort of strangely happened in the pandemic was that we actually saw, both extraordinary scientific breakthroughs, medical breakthroughs, but also this deterioration in confidence in expertise. What's your feeling about the extent to which that actually now is influencing the public debate from everything to from funding medical research through to the way we fund our health system?
Yet again, I think that's an absolutely important thing. And I think everybody who approaches the responsibility of care or looking after the community and tries to make decisions based on good science is challenged by this. And we're seeing ideas that really have no scientific basis at all, but take hold and take root. And I think one of the big things that happened is social media allows these ideas to spread rapidly. And when you study social media as you would an infectious pathogen, you find that misinformation and disinformation spreads more rapidly than accurate information. It's quite extraordinary when these things are studied. So I think it makes the policy environment incredibly difficult. And I think a lot of people are also victim of algorithms that allows you to see what you want to see. So in the old days, someone would pick up a couple of newspapers and read them, whatever. Now, people don't do that so much. They have a device that will deliver up to you based on an algorithm, something they think you will like. So it tends to be very self-reinforcing. I think we have to deal with it. I don't know how you do it, but I agree with you. It is a major threat, not only to health policy, but to good public policy generally. It's a threat, and we're looking at these existential threats at the moment, aren't we? We're looking at pandemics, and we're looking at climate change, and we're looking at AI, and all of the Pentagon's looking at UFOs. There are lots of things that potentially threaten us as a species in a way that we haven't faced before. I know my own children, face an environment that's very different to the one I faced when I was their age. Dealing with it, I think, has to be a high priority if we are going to get good public policy and good government, not only here but around the world, Laura.
Tess Economou.
Thank you very much for your time today. The number of graduate doctors choosing general practice has plunged to record lows. What needs to be done to attract more doctors to general practice?
Well, it's a critical question. I think Mark Butler, the Federal Health Minister himself, has acknowledged that this is just such a key issue for the country. So when I was a medical student, I admit this was a long time ago, general practice was really seen as a great place to be and to build a career. There was a gentleman in Brisbane who billed himself as Dr. Warwick of the AMA, and he was your family doctor, and people would ring the radio and talk to him and get advice. It was really seen as a fantastic career, and I had the luck of doing my GP placement with him, with Warwick, and it was great. But over time, I think we've seen a number of forces at play that have made it a less and less attractive career option. And you're right, we're now seeing training places for GPs, despite the number of medical graduates, not being filled. When you survey young doctors who've recently graduated, general practice maybe not for me, only a small proportion think it might be the right fit for them, which is terrible because it can be an extraordinarily fulfilling career. So I think if we're looking at how we build this up again and again make it a great career destination for people, we have to say we value it. And I think one of the messages that successive governments have delivered to GPs is we don't value you. And I think people want to be part of a team that's valued. I think part of that is the funding model. And I know that Dr. McMullen, my Vice President, has spent an enormous amount of time on the Strengthening Medicare Task Force, working directly with the Minister. Is that my wrap-up message?
No. Somebody being embarrassed with their phone.
Has spent an enormous amount of time getting these settings right. How do we rebuild a funding model that actually makes it attractive to people? And it should be really attractive to lots of people. And I think making sure that our jobs are not in a situation where to actually turn a living, you've got to see patient after patient after patient after patient, but funded in such a way that you can actually sit down and spend time with a patient. People have complex conditions and mental health issues, and this is almost a gendered thing. I think there is evidence that female GPs like to spend more time with patients, so it's a gendered response as well, to make sure that they are resourced and funded to provide the care that the community needs, not a model from 40 years ago that is now, turned into a churn just to keep the doors open. So I think there are lots of things you can do, but acknowledging the problem is the critical step.
Could I once again? I'm just taking whatever's here. So where is that process up to? There's been the Strengthening Medicare Task Force. There were measures in the budget. What's the next step for you and the government?
So the Strengthening Medicare Task Force, of which Dr McMullen was such a key player in this, has set some very high-level directions. It said that we can't do this fee-for-service model that rewards things as the only way forward for general practice. We need to build a funding model that's sustainable in the long term, that appropriately rewards practices for keeping the doors open and makes it viable, but also looks at the change in the way patients have conditions now as compared to the past. People have an overlay of a mental health condition, several chronic conditions, they're having trouble getting into public hospitals. GPs need to be funded appropriately to do all of that. So I think that's been acknowledged in the Strengthening Medicare Task Force, and to the government's credit, I think the budget from a few weeks ago sent a very strong signal to the nation's general practitioners. Okay, we get it. We think the time is now to move forward. I think that signalling is really important. We're very keen to move forward with the government and help them and look at the next steps. There are lots of challenges as I ran through here. Nothing is insurmountable, but I think acknowledgement of the problem has now been largely done, and we want to work with the government and say what is going to deliver a health system, what's going to make general practice healthy for Australians, because it's much cheaper to be managed by GP than have a hospital admission and see someone like me, at the end of an admission at a public hospital.
Nick Stewart.
Thanks for a terrific speech, and if you want to respond appropriately, you might say my question is terrific as well. More seriously, though, you've looked at productivity gains, and that's something that you, with your economic background, has brought forward. And yet the big productivity gains you've indicated are, for example, stopping vaping. I think that you've tweeted recently about the need to reduce sugar. Yep. These are political blockages. Firstly, what can we do to actually get the politicians to actually improve our health? What will get their focus onto this sort of thing? And secondly, if I can, you've also mentioned you were very effective in talking about GPs and specialists and all the myriad of elements that make up the healthcare focus. How is it that we can get all those elements working better together?
Well, that really is probably the best question that I've ever actually been asked, and I agree that is perfection as a question. I want to thank. We'll put our hands together for that question. Thank you very much.
Outrageous.
I think you're absolutely correct. At the end of the day, we have a political cycle. I spend a lot of time talking both one-on-one or sitting in a party room with people, our political leaders and politicians. And the fundamental thing, I guess, at the end of the day is they need to be re-elected. So we have to make sure that when they go to their constituencies, in their electorates, they're talking about things that are important to people. Now, when we survey people, we actually know that health is really important to people. So it should be an easy sell. And I think one of the things is we've got to say, well, what really is the thing that is important to our constituents? Not to necessarily big business lobbies or whatever. What's actually important to people, and build a narrative around the fact that actually everybody agrees. If someone comes to you and says, look, is your health important to you? Absolutely. These are things we're thinking of doing that might make either you or your family or your community more healthy. And I think doing it that way is the way to move forward, and putting in perspective all of these other interests and managing conflicts and from lobby groups. I represent one, but we all understand the role of lobby groups. But I think at the end, putting health at the first part of this. And the second part of your question is about all of the moving parts. And I often think of healthcare as like a helicopter. There are all of these things that are constantly in, you have a main rotor and a tail rotor all trying to work against each other to keep the thing stable. And somehow a helicopter flies. I think we need to think of the health system like that helicopter and make sure that we do have these opposing forces, but they're all working toward the common goal. And that is to give us a healthy country, because we know a healthy country is an economically prosperous country.
Best answer ever.
Thank you.
Maurice Riley, hopefully he isn't going to be quite so self-indulgent.
I'm asking this question for Tim Shaw. Tim Shaw...
okay. Hi, Tim.
Rural and remote communities are seeing some of the biggest issues to getting access to health services. What can governments do to bridge the gap, and what can the AMA do in supporting that?
Tim, that is a fantastic question. So I grew up in a small town called Mundubbera. I went to school in a place called Toowoomba. My family are in all of regional Queensland. I get completely just how difficult it is to access health services in regional areas, but how critically important it is too. And we have multiple groups. We have the rural doctors groups here who are working furiously to come up with a plan. But I think at the end of the day, one of the paradigms that is difficult and makes it difficult for communities is a kind of fly-in, fly-out workforce. And I think that while that may, solve some problems in the short term, the long term is saying, what can we do to make it viable and attractive for a health workforce who want to stay and establish and put roots down in the town? I don't just mean a doctor. I mean everybody involved in health, nurses, midwives. We're seeing around the country major problems in rural maternity services. And one of the key things that people want to do is have their family where they live. Correct me if I'm wrong, Peter, with any of these things. But yeah, I agree. 25% of Australians live outside of urban areas. There is no reason they should have any lower or any different expectations to people who live in a place like Canberra. But we have to make it attractive because this is part of our rural ambition. It's one part of the rural ambition, that if you want to stay in a town, you know that your children will be educated, that you'll have a good job, you'll have access to healthcare services and things like that that are affordable. So I think that's probably the very next step. We've looked at general practice in general. We need to look at how we can make health services sustainable in the long term and appropriate for rural Australians. Peter, are you happy with that? Thank you.
Julie Hare has another question.
Thank you. Your document here today talks about moving from sick care to health care. There's a third wing of this, which is the wellness industry, and I call it an industry because it's worth about $10 trillion nationally. There's a thing called wealthy wellness that only the wealthy can access. A lot of these treatments, services, ideas, it's an unregulated sector largely, but on top of that, there's a quote that I came across this week that said we're at an inflection point in history where only the wealthy can afford to be well and that the poor will be the only people who carry chronic diseases. I'm just wondering if you can talk me through sort of where the wellness industry sits with a healthcare sector and a sick care sector and just the division between rich and poor and access to services and good health.
Okay, well look, the questions are going on, so I'm cancelling my oxygen therapy session that I was booked to go to straight after this. I think it's a really good point, but this is not new. If you go back to ancient Rome, a lot of the writings are about exactly what you talked about today, all of these wellness things that people, even in those days, wanted to indulge in. And we know that in Australia, for example, more is spent out of pocket on things like vitamins and supplements than on prescribed medication. It is a big thing, it's a profitable thing. That's fine, that will drive marketing and people are very interested. I think one of the key things that separates or makes other therapies, part of the paradigm, attractive is time. If I go to my GP, they're normally frazzled, they've got a full waiting room, they know they've got to see a lot of patients and they will deal with it quickly. A lot of these wellness people will sit down with you and take their time going through all of your problems and you really feel heard. And that's a thing that's incredibly satisfying to people. If I go somewhere and they just listen to me talk about my problems for ages and take them really seriously, I'm happy to pay you for that. That makes a lot of sense to me. So I understand the lure and the attraction of all of these things. I think it's important that we always approach them from the perspective of saying, what does the evidence tell us about these things? What does the evidence tell us about the effectiveness of what you're spending your money on? I don't know. It's a difficult thing to manage. I'm not running down the wellness industry in any way whatsoever. And in fact, I'm saying I understand why it's so attractive to people and why people are so attracted to it when they perhaps have some experiences of underfunding and undervaluing of the health system here. But I think if you look at that gap between rich and poor and their health, I actually was invited to the Economic Society of Australia here in the ACT a few years ago to talk about our genetic future. And I think the next big thing is we understand more and more about human genetics. We understand a lot of our health is programmed in our genetics, and I think the big divide is going to come when people use technologies like IVF, select embryos that have genetics which reduce the risk of disease, and that is the basis of the next generation. We're seeing this in America at the moment and some places overseas. And the cost of IVF and the cost of that technology will leave a generation of people alone. So we'll have genetic haves and genetic have-nots. And I think that's the next frontier. And I share your concern. I think if we get to that stage, as a society, we're in big trouble.
Thank you.
Simon Gross.
Let's talk about vaping and prohibition. I think 2 days ago we reported that the TGA had fined a Sydney mob over 500 grand for bringing in almost 400,000 vaping products. And every now and again we see out in normally rural Victoria, people are busted for growing hectares of tobacco, dobbed in by their neighbours. I have a friend who is a vaper. He gets his gear from somewhere in Western Sydney. He also gets packets that look like Marlboro, $15 for 20. Prohibition creates a black market, creates profits that people take the risks that I'm talking about. But all you and the governments do is carry on the same, we're going to stamp this out, blah, 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 blah. Can we get some insight? Can we get cleverer?
Okay, again, a very, very hot topic, and it's a hot topic with a lot of the people I deal with. About a month ago, just before the budget, when the Health Minister announced that they were going to move to a prescription-only model for all e-cigarettes, I got a call the next day from a school principal that I know. And he was almost in tears of gratitude because we'd talked about vaping. And he said, I cannot thank you enough. I want you to pass on to the Health Minister from me how grateful I am as a teacher, for my colleagues, that someone is finally acknowledging this is a problem and doing something to help settle it down. So e-cigarettes were invented about 20 years ago, and they were initially invented by a pharmacist as a way to perhaps replicate those hand-mouth movements that came with tobacco smoking that were very, very difficult in other methods of giving up tobacco smoking. A lot of the evidence initially was promising, but of course they have been supplanted as a recreational thing. So we have a small proportion of e-cigarettes that are prescribed at the moment as one of a suite of things that can help you give up smoking. But a massive market in vaping e-cigarettes, some of them disposable, that befoul our societies with all of this ecologically catastrophic thrown away vapes after a single use. And most of the vapes that people inhale have virtually no quality control at all, even though they're sold as non-nicotine. They commonly have nicotine in them. Even if it's not tobacco smoke, they have things like nail polish remover that you're inhaling into your lungs. And they are, for the first time, being associated as a gateway to smoking for a generation who'd given up smoking. So they're a big problem. I think everybody acknowledges that they're a major problem. And I completely acknowledge the issues around the black market. I get it completely. I know that kids can, do on a Facebook page and someone will ride up with a motorbike and give them e-cigarettes and things like that. But we have to start somewhere. I think we probably are at a point where we have an opportunity to do something as a first step and build on that. I think the idea of saying, I'll just bugger it, just let her run and make some money out of it, as I hear some people taking, is the wrong approach. And if, again, as I said earlier on, we take the approach of what the evidence tells us. The evidence tells us that e-cigarettes are not good for you. And even if you get off a tobacco cigarette, there's no pathway to get off a vape. So we think making sure that the people who are trying to give up cigarettes work with a healthcare professional to help them is important. And people who don't or take them up purely for recreational purposes, particularly kids, particularly vaping is a thing of young people, we need to send a strong signal that it is harmful, that we don't want the next generation.
But kids are going to do stuff they're not supposed to do. That's
we all get that. Yeah. But I don't think it's a time where you just roll over and say, I give up. And I think that's the thing. I think we're getting a signal now that says we take it seriously. When teachers are ringing me in tears, not saying my kids have misbehaved for a change, but saying we're worried about vaping, then I think they're the calls I like to get.
Well, finally, if I could ask you, you're a bit of a mad tweeter.
Oh, no.
And amongst...
Much to the annoyance of the comms team.
You tweet pictures of Roy Kent, so that's only to be endorsed. But on a more serious note, a few days ago you tweeted that I speak as an obstetrician, gynaecologist who's been involved in the care of many victims of sexual assault. Why in God's name would any woman now come forward to report these crimes after seeing the current media horror? I just wondered whether you could reflect on what the outcome of the current media horror might be in a health sense.
A lot of people have read different things into that. But I want to bring my perspective to that. As an obstetrician and gynaecologist who works in public hospitals, over the years I have been called to treat some of the most appalling injuries over the years. I'm not even going into things that I've had to treat and manage for women because it will be triggering and I would feel like I'm betraying some women I've managed. But even away from that, so often I try to help and treat people and it comes out that they have been a victim of sexual assault. And many of them just find these discussions so triggering. And when we're in an environment where, and I know some of the players involved in the whole thing we're talking about here, we're seeing some of the discussion, not just the reporting, but in particular the comments that seem to come with the reporting and the things on social media about this. I cannot imagine how triggering this would be for the tens of thousands of Australian women who have been victims of assault and never told anybody, kept it inside. And I think we need to be incredibly careful in our discourse about this because it may play politically one way or the other, but by God, it is harming a lot of women. And if a young woman sees this dissection of events in the media, is it really going to say, wow, I want to go and report this immediately? I think it's a terrible disincentive. And I think my reflection is that many of the women I treat would just retreat further into this shell and not want to report what should be a reportable crime to bring the perpetrators to justice.
Professor Steve Robson, thanks so much for talking to us.
Thank you.